Morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. I'm your host today, Eric Lim, and it's a great delight for me to present Professor Neal Navani, who is a consultant respiratory physician, to talk about determinants of lung cancer risk in never smokers. All this education brought to you at no cost, thanks to our sponsors, AstraZeneca, Medtronic, and Medina, the Science of Care. Neil, over to you.
Eric, thank you very much for the kind introduction and invitation to give this grand round, and congratulations on building such a impressive portfolio of education for the world. That's fantastic. I have a few disclosures prior to delivering this presentation. So I'm going to cover 4 areas regarding lung cancer risk in never smokers. So first of all, I want to clarify for everybody the epidemiology of lung cancer in never smokers. We're then going to dive deeply into the risk factors and how they may be associated with lung cancer risk in never smokers. I'm going to show you for the first time a snapshot of some UK data in this area, and then discuss some of the important implications that this data should have. So first of all, let's look at the epidemiology of lung cancer. So the solid line here is the prevalence of smoking, and you can see that there was a real inflection in 1970 where suddenly the prevalence of smoking really started to drop due to very successful public health measures in the UK. So this is UK data showing that smoking prevalence has significantly dropped. And you can see from this dotted line, which is the incidence, that the incidence of lung cancer in men in particular has virtually fallen in parallel to the drop in prevalence of smoking, whereas the incidence of lung cancer in women has very slowly increased independent of the drop of prevalence of smoking in women. And I'll come back to the impact of gender shortly. So, lung cancer in never smokers is defined really in the literature as lung cancer occurring in people who have smoked less than 100 cigarettes in their lifetime. And most estimates would suggest that's up to 20% of people with lung cancer with a median age of approximately 67, so slightly less than a standard lung cancer cohort. Importantly, about 20% of females with lung cancer have never smoked, and that's considerably higher than males where it's about 9% of males with lung cancer. And as we know, the predominant histological subtype of lung cancer in never smoking is adenocarcinoma. So this is a really thought-provoking slide, I think, taken from this review in Nature Reviews Clinical Oncology from a couple of years ago now. And it shows the number of deaths in 2020 from lung cancers. And you can see here that if we consider lung cancer in never smokers a separate entity, it's actually the 5th most common cause of cancer death worldwide. Tobacco-related lung cancer still way out ahead in terms of number of deaths from cancer, followed by liver, stomach, and breast cancer, and then globally lung cancer in never smokers. So it really is perhaps an under-recognized but major public health issue. There's a lot of debate as to whether the incidence of lung cancer in never smokers overall may or may not be increasing. And there are a number of studies that perhaps provide some conflicting evidence about this. This is a really interesting study carried out by colleagues at UCL. They used a cohort of 3.7 million people in the UK. And with a cohort approach, it can account for 2 really important factors. So first of all, that the number of never smokers over time has increased. As we saw earlier, the prevalence of smoking is decreasing. So the number of never smokers increasing over time, as well as the population aging over time. So we have to take into account those 2 factors when we're considering our denominator when we work out the incidence. And what this study showed is actually the incidence of lung cancer in never smokers is actually reducing over the past 20 years. And this has fallen dramatically in men while remaining fairly stable in women. What's really clear, however, is that in our lung cancer clinics, the proportion of lung cancer in never smokers is clearly increasing. And there's multiple studies to confirm this. This is one of the largest ones of 10,000 lung cancer cases between 1990 and 2013 that showed the proportion of lung cancer in never smokers increasing from 8% to 15%. So almost a doubling of proportion of lung cancers in never smokers. And that's perhaps what we see in our clinical practice, where the number of lung cancer in never smokers is perhaps doubling. So two irrefutable facts about lung cancer in never smokers is that it's more common in women and more common in East Asians. And overall, approximately 2/3 of lung cancer in never smokers occurs in women. And this is even higher in Taiwan, when up to 83% of lung cancer cases among non-smoking individuals occur in women. Another important point about lung cancer in never smokers, particularly in East Asia, is that it tends to occur at an earlier age, typically in 50s as opposed to in 60s in the Western world, and lung cancer in smokers tending to occur in the 70s. So several distinct epidemiological patterns that we see for lung cancer in never smokers. What's really clear as well from several studies is that there's such an important environmental component in developing lung cancer. If we look at this really fascinating study of women of Japanese or Korean background who are living in the US, they actually have a significantly lower incidence of lung cancer than those living in Asia. So this regional differences really highlight the importance of an environmental and genetic interplay. So let's dive deeply into what are the real determinants of risk of lung cancer in never smokers. And it would be important that we start with environmental exposures. And first on that list has to be radon. Now, this is perhaps not as well recognized as it should be in the UK, but in the US, the CDC estimates that radon causes about 21,000 lung cancer deaths per year. So radon, as we know, is a colorless gas, odorless gas. It arises from the radioactive decay of uranium-238 and should be considered a class 1 carcinogen. And actually, the US CDC recommends that all homes in the US should be tested for radon. They have an entire fact sheet on the CDC website about radon, and it's stated that radon is the #1 environmental cause of any cancer in the US and the #1 cause of lung cancer among people who have never smoked. It increases the risk of people who have smoked as well by 10 times for developing lung cancer. And slightly staggeringly, about 1 in 15 homes in the US are thought to have high radon levels. And they suggest that high radon levels are the equivalent of smoking 8 cigarettes per day. So this is perhaps something that is clearly thought about very clearly in the US, but perhaps less well so in other areas. Having said that, there are detailed radon maps that are available. This is one of the UK showing that actually there are a significant proportion of homes in the UK that have high radon levels. And perhaps it's time that we need to take these levels a lot more seriously and look at the impact of them on the incidence of lung cancer in those regions. Another really important risk factor that I think has come to the fore in the last few years is pollution. So there's been a lot of work done on the impact, particularly on outdoor pollution, on the development of lung cancer. And a centerpiece of that is some amazing work led by the Swanton lab at the Crick and UCL that really clarified the potential mechanism by which pollution can drive lung cancer. And they made several fundamental observations in this landmark publication from a couple of years ago. First of all, they found that normal lung has pre-existing oncogenic mutations. So they found that normal lung may have EGFR mutations. They then showed that exposure to PM2.5, a particulate matter commonly found in environmental pollution, induced interleukin-1 beta, which caused differentiation of EGFR mutated cells into a cancer stem cell state, which then resulted in tumor formation. So normal lung can harbor EGFR mutations, and there is a mechanism by which pollution via IL-1 beta can promote tumor formation. And obviously this work is being taken forward, particularly looking at ways to intercept IL-1 beta to prevent lung cancer formation. So that's outdoor pollution, but clearly we have indoor pollution as well, and strong epidemiological evidence about cooking without ventilation and indoor pollution from wood burners would also suggest that this is a really important determinant of lung cancer risk in those who have never smoked. We also have environmental exposure to asbestos and secondhand smoke that we also know clearly increases the risk of lung cancer in never smokers. So we've got a number of environmental factors there that we've got increasing evidence from an epidemiological and mechanistic basis that will cause lung cancer in never smokers. We also have strong evidence about the importance of family history. So this is from a European study, a case control study of over 20,000 cancers and over 20,000 controls, and they found a high odds ratio of 1.25 with a first degree relative with lung cancer for developing lung cancer. And particularly if there's an affected sibling, the odds ratio is 1.44. So a real significant increase in risk with family history and lung cancer. And this is really exemplified in the TALENT study. The TALENT study, as you may know, carried out in Taiwan, is a screening study of participants who have never smoked. So they have the age of 55 to 75, never smoked, but also have an additional risk factor for lung cancer. And what they found is that family history really was a vital part of picking up lung cancer in their screening program. They found a significant difference in those that had a family history compared to those that didn't, such that 63% of people with an invasive lung cancer had a family history. So one of our PhD students within our data science lab within UCL, Dr. Naidu, has really taken this work forward now and has begun by carrying out a systematic review and meta-analysis of all of the risk factors involved for lung cancer in never smokers. Uniquely, this work has been co-designed and delivered with a public group that consists of several patients who have lung cancer and who've never smoked. It's also been done in conjunction with the MRC Clinical Trials Unit and Meta-Analysis Group. Excuse me. So we made some interesting observations simply by reviewing the literature, putting together all of the data, and actually able to quantify the impact of some of the risk factors. So here you'll see that rheumatoid arthritis in several studies is a very clear risk factor, not just due to ascertainment of imaging, but there appears to be a very clear and consistent effect of rheumatoid arthritis on the incidence of lung cancer. And then, as we would expect, the effect of passive smoking exposure, also the impact of pollution, but we can see also the magnitude of these impacts on lung cancer risk. And that's allowed Dr. Naidu to really produce this Venn diagram of risk factors for lung cancer. We can see in the center that there are many risk factors that are common universally across the world, including rheumatoid arthritis, female sex, previous cancers, and then the important environmental factors of passive smoking and pollution exposure. And then in East Asia, we've seen the major impact that family history can have, as well as some other factors that came out in meta-analysis. Whilst in Western countries, slightly different factors, including ethnicity and wood-burning stoves, as well as pleural plaques, and importantly, pesticide exposure in single studies. So this meta-analysis really does help us, I think, to really start to tease out what some of the important risk factors are for developing lung cancer, obviously with the thought of going forward to potentially producing a risk model for pulling out from the wider population people who are at a higher risk of developing lung cancer. And really, to continue this work, Dr. Naidu has taken one of the largest cohorts ever assembled of lung cancer in never smokers from the National Lung Cancer Audit dataset, and also linkage to other datasets within the UK Cancer Registry. And she's assembled a dataset of over 10,000 people, 10,000 people with lung cancer who have never smoked, and is really starting to dive into this data, and really interesting insights are starting to appear. This is not yet published, so grateful if you could not share this slide, but the median age in the UK for lung cancer who never smoked was 73, 65% female gender. And one really interesting immediate observation was that the deprivation gradient that we traditionally see in smoking-related lung cancer is not observed in lung cancer in never smokers. So here you can see the least deprived group have the highest incidence of lung cancer. And Dr. Naidu's got lots of other really important information on that, including stage at presentation, ethnicity, important genomic information and outcomes. And many of those findings are going to be presented in our upcoming national conference, the British Thoracic Oncology Group conference meeting next month. Just briefly, a lot of these data, when we look at lung cancer in never smokers, comes with significant limitations. And that comes down to recording of deep environmental exposures for our cancer patients. We often lack smoking status in many datasets. The Big SEER dataset in the US, for example, does not include smoking status. It's very difficult to measure in datasets pollution exposure over time, let alone indoor pollution. And even in our own cancer registry, which is one of the most complete in the world in the UK, we have incomplete, approximately 30% missing data for smoking within the cancer registry. So this is clearly something that we need to improve. So just to wrap up, what are the implications from this, from lung cancer in never smokers, and what we can learn about some of the epidemiology and risk factors? Well, I think it's a really good example of a distinct environmental, germline, and somatic interplay. I think they're all working together to increase risk of lung cancer in certain individuals. And we clearly need a novel model to push forward early detection. We can't screen the entire population currently with CT. We need a novel model. And by understanding those risk factors, we may be able to start to build that using age, gender, pollution, family history, rheumatoid arthritis, radiation exposure, and obviously radon as well. So can we hopefully work together in building that novel model across different populations? I think it really also highlights the importance of environmental policy. We need very clear national and international environmental policies on reducing pollution exposure to reduce lung cancer incidence. I think that's clear. We need to improve public awareness, which will obviously, hopefully, prompt earlier diagnosis of lung cancer in never smokers. And we need to improve our data, improve environmental exposures, including tobacco and pollution to cancer registries. And really thinking about this area a lot now over the last few years, I really come to consider lung cancer in never smokers as a separate entity. And I really think we should think about that as a lung cancer community going forward. It is epidemiologically and biologically very different to smoking-related lung cancer, and in my view now should not be considered a subset simply of lung cancer. I particularly want to acknowledge colleagues at UCL, particularly Dr. Naidu, who's doing her PhD in this area funded by the NIHR, and also the OLIVE Patient to Public Representative Group. Again, Eric, thank you very much for the invitation, and I'm happy to engage with our discussion.
Thank you very much. Great presentation, Neil. Can I maybe start by asking a few questions? Many people or researchers talk about environmental factors, but the environmental factors don't quite fully discrepancy in gender. In our prompt series we published quite a few years ago now, we noticed that in early stage lung cancer, the male-female gradient was higher at 4.5 to 5 compared to men. And if environmental or anything that's radon or anything that's exposed in the whole world, then there wouldn't be such a gradient. What do you think are the differential contributions? Or presumably each one won't be equally weighted.
Yeah, and I think the point you raise about gender is really, really vital here. And I think this is a real focus of work and understanding, because we don't have a very good explanation for this currently. Lots of work has been postulated on hormonal impact. Estrogen receptors have been looked at in detail. There's not really a good explanation for this. One thing that we're very bad at measuring is indoor environmental exposure. And there is quite a bit of evidence now to suggest that certain ways of cooking, certain types of cooking, and the smoke that results from that, and perhaps lack of ability to remove smoke from the indoor environment, can be related to a significant increase in smoking risk. That may explain differences in, for example, lung cancer in never smoker incidence in Northern Europe, in, for example, Sweden, Norway and Finland, where it's a bit lower, compared to East Asia, where cooking differences are, there's a big difference in cooking and perhaps indoor pollution levels. So, and does that perhaps feed into the differences in gender that we're seeing? So I think there's a lot more to be understood here. And I think the epidemiology, to be honest, is only going to be able to take us so far. I think we're going to have to be able to look at genetic risk factors. We're going to have to be able to dive into genome sequencing studies in more detail. And I think we're going to have to look as well at biological mechanisms to help to understand this as well.
And I think I fully agree with that. I think imaging and risk factor modification, risk identification can only get us this far. And it's going to be the genetics that's going to be the real game changer in this field. Now, can I ask, you've done so much epidemiological research and you're so active in this field, right? You've identified the increasing incidence, so on and so forth. Coming back to your MDT during the clinical day-to-day practice, does it change your view on the incidental GGO in the female 60-year-old woman coming to your MDTs, the management?
Yes, and I think that's a fair question. So we, as you know, have very clear guidance on management of ground glass opacities that we find in our clinical practice. I think it's very important that we distinguish when we're talking about subsolid nodules, we must distinguish pure ground glass opacities to subsolid ground glass opacities. And sometimes the literature can get very confused between those two. And part solid nodules that contain a solid component, as we know, have a very high incidence of lung cancer, whereas pure ground glass opacities probably have a slightly lower incidence of lung cancer. And pure ground glass opacities very rarely cause cancer death. And I think this is a really important point to take away. I've never seen anyone die from a ground glass opacity. So the important point about it, however, is that it can be considered a biomarker for lung cancer risk, not just in the nodule, where a pure ground glass opacity can, over perhaps a long period of time, develop into a lung cancer that may impact that person's life. But more importantly, they are at increased risk of developing a primary lung cancer elsewhere in the lung. So when I see a patient with a pure ground glass opacity in the lung, I'm thinking two things. One, yes, at some point we need to watch this. Will this become an invasive cancer that will impact that person's longevity? But also, and equally, and perhaps more importantly, this person is perhaps at an increased risk of developing a primary lung cancer elsewhere in their lung that is far more likely to impact their longevity. So I now consider pure ground glass opacities, persistent pure ground glass opacities, I should say, to be a biomarker for lung cancer risk. And there's an upcoming British Thoracic Society guideline that's reviewed this evidence in detail, and I hope that's going to be published later on this year.
Thank you. Adrian Marchbank is asking if and when they should start screening for non-smoking lung cancer. He's based in Devon and Cornwall, presumably high radon exposure.
Yeah, so I think the first thing I would say is buy a radon monitor. They're available on Amazon, and have a look at the average levels. I understand that radon levels can fluctuate quite a lot on a day-to-day basis, so it's worth taking an average over time. But the question about screening is clearly the most important question in this area. We've seen the real positive impact of screening for lung cancer in smokers, and we all know about the clear mortality benefit for that. So with the rising proportion of lung cancer in never smokers, how can we offer screening in a risk stratified way for people who have never smoked? And I think the best way to do that is to be able to develop a functioning risk model that is going to predict lung cancer risk at a similar rate that we see in the smoking population. So around the 1 to 2% risk at 5 years, we have the evidence from the smoking population that it's reasonable to introduce a low-dose CT screening program for those. So if we can build a validated risk model in a particular population to show a risk of 1 to 2% at 5 years, then I think we can start to consider low-dose CT screening for those patients. Clearly, there's also a lot of work being done on other ways of screening, looking at circulating biomarkers, looking at circulating tumor DNA, and other potential ways of determining lung cancer risk in this population.
Definitely, I think totally agree with that. Dr. Anna Patel is asking a little bit more about cooking fume exposure. Any idea about particle types, whether that would actually also influence the non-smoking lung cancer risk maybe here in Europe? Is it just an Asian thing?
Yes. So again, there's a lot of active interest in this area where smoke from indoor pollution, cooking in particular, is being analysed. I have to say it's not well understood currently. There's a lot more that is well understood about outdoor pollution from exhaust and the very clear role, as we've discussed, of PM 2.5. We know about PM 10 as well. I think, certainly to my knowledge, the actual particulate matter from indoor pollution from cooking particular oils, cooking and frying particular vegetable matter, and also from wood-burning fires indoors is still really to be clarified. To my mind, however, some of the epidemiological data is quite strong in that area. And I think this is an area where there would be an opportunity for public health intervention and more public knowledge about this to potentially reduce the incidence of lung cancer in those groups exposed to indoor pollution.
Thank you. My final question, coming back to your risk modeling, it's interesting that when the talent study did the all-comers in doctors, the actual non-smoking lung cancer risk was higher than the actual, US screening studies themselves in Western heavy smokers. One approach or thought in Asia is voluntary screening. People just turn up and get a CT. And I think that's currently being advocated in some parts in Taiwan and China. What are your view on people just turning up on the door, knocking and just say, hey, I'm 60-year-old female non-smoker. Can you give me a screen?
Look, I think there are two aspects to that. One is, do we have the evidence? And two, do we have the resources? And I think for both of those currently, we're slightly below the standard that we set ourselves within the UK. So I can't see that currently quite happening. Although, look, in principle and in the future, I really think open access is vital. In fact, in the National Cancer Plan that was published in the UK on the 4th of February, one of the things that was mentioned in there was open access to chest x-rays for people who are worried about the risk of lung cancer. Now, perhaps that's not going to be the most useful investigation for picking up lung cancer in never smokers, but that's a start, perhaps particularly for the smoking population, and increasing access, which I think is the problem that initiative primarily is addressing. But I think currently, I'm not going to say on your webinar, Eric, that we should invite everybody to above a certain age to come and have a CT scan. I think what we need to do is focus on the research to develop that really accurate and validated risk model so that we can then invite an evidence-based population and really know that we're screening the right population and hopefully reducing lung cancer mortality longer term.
Amazing. Thank you very much. And once again, thank you to our sponsors, AstraZeneca, Medtronic, and Medela. Thanks of care. And especially to you, Neal, for leading this initiative here in the UK and doing so much work to try to improve survival of non-smoking lung cancer.
Thank you, Eric. Thanks, everyone.
Next week, we have Long Jiang from Shanghai talking to us about refining risk strategies in high-risk non-smoking populations. And I'll look forward to see you all then. Goodbye.